Okay, so having looked at some of the basics in the previous module regarding perioperative VTE prophylaxis in surgery patients as a whole, let's turn attention to some nuances related to specific types of surgery patients. I believe 4 specific groups warrant additional consideration or separate consideration. Trauma patients, which we're going to focus on during this podcast, and then those patients receiving epidural catheters or other neuraxial procedures, surgical oncology cases, and bariatric patients, which we'll discuss in the final VTE prophylaxis podcast. With the exception of very severely injured patients presenting with coagulopathy of trauma, certainly a noteworthy subset of cases which we devote extensive separate discussions to, the majority of moderately injured and severely injured trauma patients are actually prothrombotic and at increased risk of VTE secondary to tissue injury and release of tissue factor, immobilization, and or decreased venous blood flow and stasis. Data out of Denver and elsewhere demonstrate a relative hypercoagulability to be present very early in many trauma patients' presentation. The subset of trauma patients at risk and the magnitude of this risk were defined in a well-conducted single-center Canadian study published in the New England Journal in 1994. This study consisted or was conducted between January of 1989 and May of 1991 by the trauma team at Sunnybrook in Toronto as they prospectively evaluated 349 patients with ISS greater than 9 with routine lower extremity venograms. And they observed in doing this a 58% incidence of lower extremity DVT and an 18% occurrence of proximal lower extremity DVT in the absence of any VTE prophylaxis. And this certainly contrasts dramatically with a 0.1 to 0.2% incidence in the general population. So while the elevated risk of VTE for patients post-trauma is widely recognized based on this study and others like it, the appropriate balance between early initiation of venous thromboembolism chemoprophylaxis and avoidance of promotion of bleeding complications by these same medications are incompletely adjudicated by existing literature to the point of there being some variability even across consensus guidelines. The reality is that there are often too many variables in many of these complex patients to permit dogmatic adherence to an algorithm a significant amount of the time. In order to do the best for our patients, we need to have a good working knowledge of existing recommendations and the data behind them. But just as important is maintaining personal engagements in patient-specific cases to be able to apply our knowledge in a tailored fashion with the expert audacity referred to by Dr. Atul Gawande in the surgical quality and safety literature. So many of these patients are unfortunately too complex for just cookbook approaches, and we have to be able to take our knowledge of the literature, our knowledge of the guidelines, and then apply it on a selective basis and with a certain amount of art onto these what are often very complex patients. Now, the trauma literature regarding VTE prophylaxis, while far from perfect, is significantly more robust than most other surgical subspecialties. And this is especially true regarding dose and frequency variabilities and how to best dose low molecular weight heparin. Some of the most pertinent data recently comes from 2 studies published alongside each other in the December 2016 Journal of Trauma and Acute Care Surgery. The first paper was from the UCSD trauma team looking at a semi-weight-based dosing approach in which patients were placed into 3 dosing ranges based on weight, with patients 60 kilograms and under receiving 30 milligrams BID of enoxaparin, patients weighing between 61 and 99 kilograms receiving 40 milligrams BID, and those greater than or equal to 100 kilograms receiving 50 milligrams BID. They then compared anti-10A levels of the protocol group to a control group administered non-weight-based dosing, with the majority receiving 30 milligrams of Lovenox BID. And the study group was found to have significantly improved anti-10A effect without an increase in excessive anti-10A suppression. While a trend toward lower VTE rate was seen with the protocol group at 2.8 versus 4.4%, this did not reach statistical significance. Also not statistically significant was a slight trend toward increased bleeding with higher dosing. Perhaps more concerning was the observation that around half of the VTE complications which did occurred in patients with a therapeutic level of anti-10A of 10A suppression, raising concern about how accurate the barometer anti-10A levels are for assessing VTE prophylactic efficacy. The second publication was out of Miami and retrospectively compared patients receiving anti-10A level guided Lovenox dosing to a historic group at that center. And while the study group, here shown in yellow or highlighted in yellow, demonstrated significant benefit with a lower DVT rate at 7% versus 20%, the overall VTE rate and PE rate did not reach statistical significance. The PE rate was actually slightly higher in the anti-10A guided group. Around the same time, JAMA Surgery published a study out of Cedars-Sinai with a prospective study group of 87 trauma patients, highlighted again in yellow here, who received a starting dose of Lovenox 30 milligrams BID, which was then titrated up in 10 milligram increments based on anti-10A testing. And this was compared with a historic group, highlighted in orange here, of 118 patients who received a static dosing of 30 milligrams BID. 73 of the 87 study patients, or 84%, required some dose adjustment, and 57 of those 87, or 65%, stabilized at 40 milligrams BID. The adjustment group, in regards to outcomes, had a lower VTE rate at 1.1% versus 7.6% in the non-study group. The recommendation of the authors was therefore to initiate low molecular weight dosing of heparin, low molecular weight heparin dosing at 40 milligrams Q12 hours, and then adjust it based on anti-10A levels. I think an important observation from this experience is that very few patients, though, required greater than 60 BID of enoxaparin. And we'll emphasize this again later on, but I do think it's worth just taking a pause to look at this, because based on this literature, we're going to see that there's a recommendation in some of the guidelines for heavier patients dosing up to 0.5 milligrams per kilogram BID. And for particularly morbidly obese patients, this could lead to significantly higher doses of Lovenox than 60 BID. And I do not believe that that is supported by this study or others in the literature. And so I have a little bit of heartburn with the recommendation for heavier patients receiving dosing of 0.5 milligrams per kilogram. I think the data really suggests, yes, some weight adjusted prophylactic dosing, but likely topping out at somewhere between 60 and maybe you could even argue up to 80 milligrams BID. But outside of that, going higher than that, I'm just not seeing support for it, neither in the trauma literature nor in the bariatric literature. And we'll touch upon this a little bit more as we go forward, but I think that's an important observation from this study. Also important, though, was the fact that the weight adjusted and the adjusted dosing here led to better outcomes in regards to VTE occurrence. A subsequent publication from the same group in 2021, published in the World Journal of Surgery, provided further support for this approach, showing it to be associated with decreased DVT and PE rates, as well as overall VTE rates, as noted here, again with the study group highlighted in yellow and the control group who received static dosing in orange here. Now, it is important to recognize that elderly patients, TBI patients, spinal cord patients, and those at risk for ongoing bleeding, as well as those with renal failure, were excluded from this approach. So this did not include patients with significant CNS injuries, patients with ongoing significant risk of bleeding, such as from non-operated solid organ injuries, and patients with renal failure were not included in this analysis. Utilizing data from these and other primary literature sources, several consensus guidelines regarding VTE prophylaxis in trauma patients have been developed. I would submit the two most helpful guidelines currently are those endorsed by the AAST, as pictured here, and the Western Trauma Association, as pictured here. Now, there are many similarities between the two, but also a few notable differences, and we'll discuss these as we move forward. Both guidelines recognize that patients with ISS less than 9 who are ambulatory and don't require more than a day hospitalized don't typically require chemical VTE prophylaxis. Here in the AAST, here in the Western Trauma Association guidelines. Excluding patients with active bleeding, coagulopathy, traumatic brain injury, or spinal cord injury, all patients with ISS greater than 9 requiring admission should receive both VTE chemical prophylaxis and mechanical prophylaxis, as noted in the orange here in the AAST guidelines and here in the Western Trauma Association guidelines. Unless contraindicated by renal failure, chemical prophylaxis should be with low molecular weight heparin, Lovenox, or in some instances Fragment, depending upon what your pharmacy purchasing agreements are. And this should be done in an age and weight-based fashion. The AAST guidelines emphasize adjustment of dosing in obese patients more than the Western Trauma Association recommendations. And I think there's utility to that based on the previously reviewed data. I'm just a little concerned at the endpoint, which was arrived at 0.5 milligrams per kilogram BID, and I would be more comfortable with a semi-weight-based dosing topping out somewhere at 60 milligrams BID to maybe 70 milligrams BID. Both the AAST and the Western Trauma Association recommendations recognize that with renal failure, as defined by a creatinine clearance of less than 30, low molecular weight heparin may be risky, and therefore recommendation is for unfractionated heparin in those patients. With the Western Trauma guidelines, just a flat rate of 5,000 units Q8. With the AAST recommending 5,000 Q8 if their BMI is under 30 or 30 or under. If it's greater than 30, then a recommendation for 7,500 units of unfractionated heparin Q8 hours in patients with a creatinine clearance of less than 30. And both the AAST recommendations as well as the Western Trauma Associations mention considering, well, in AAST they just say do it, but Western Trauma says consider adjusting by anti-10A level testing. And this sounds good conceptually, but again, the data on it, as we've touched upon a little bit, is mixed. It's also a little bit awkward and difficult to do. And in the absence of clear benefit, I think most of us have shied away from doing this. But I think some weight-adjusted dosing is pertinent, or is prudent based upon the literature. But anti-10A testing, consider it. Again, most of us, I don't think, are doing that just because it's somewhat onerous to do. And again, the literature is mixed in regards to it really making a difference. Both the AAST and WTA recognize that actively hemorrhaging patients TBI patients, and patients with vertebral and spinal cord injuries are high-risk patients in whom initial VTE chemical prophylaxis may not be appropriate, as highlighted in the red area here of the AAST guidelines and here in the Western Trauma Association guidelines. Given some ongoing limitations in data and controversies in management, we'll look at each of these high-risk scenarios in more detail. And as we do so, we'll lean fairly heavily on the excellent multi-center authored review article published earlier this year in the Journal of Trauma and Acute Care Surgery by Dr. Schellenberg and colleagues, who provided a solid review of the pertinent literature as well as insights obtained at a recent consensus conference. Firstly, if a patient has active bleeding or coagulopathy on presentation, then obviously VTE chemical prophylaxis is not appropriate until bleeding is controlled and coagulopathy is corrected. Once patients are hemodynamically stable with stable hemoglobin and no ongoing coagulopathy, then within 24 hours, it's usually appropriate to start chemical VTE prophylaxis. And that's reflected in both the AAST and the WTA guidelines. Solid organ injuries being managed non-operatively, an issue primarily regarding the liver, spleen, and kidney, frequently pose more potentially problematic situations as the body's coagulation system is being leaned on a bit harder. So there's been a tendency to withhold VTE chemical prophylaxis out of concern for the risk of rebleeding in such cases. There is, however, now some literature advocating for the safe and effective initiation of VTE chemical prophylaxis within 48 hours of such injuries, provided there's not ongoing bleeding. A prospective experience on this topic, highlighted in yellow here, was published in 2019 and involved 118 patients cared for at LA County with decreased DVT occurrences without increased risk of bleeding being observed with early VTE chemoprophylaxis. And early was defined as less than 48 hours in this instance. No change in PE incidence was noted, however. Several other retrospective single and multi-center trials, highlighted here in green, echo these findings. Now, limitations to this data is an underrepresentation of higher grade injuries, grade 4 and above were underrepresented, as well as patients with multiple sites of solid organ injury. So it was not well represented when you have like a liver laceration combined with a spleen laceration, for example. Additionally problematic is non-uniformity in the utilization of angioembolization in these series of studies, and whether performance of angioembolization represents a bleeding complication associated with early VTE chemical prophylaxis or not. That's not been looked at consistently. A prospective multi-center AAST trial is currently accruing patients and should enhance our knowledge on this subset of trauma patients. Looking at this primary literature seems, to me at least, to make the guidelines appear a bit over-aggressive regarding early introduction of VTE chemical prophylaxis in the setting of solid organ injury, with the AAST recs calling for immediate prophylaxis of grade 1 through 3 lacerations, irrespective of the extent of bleeding. And, I think it's important to remember that while injury grades help prevent or help predict risk of bleeding on a population basis, they are not necessarily predictive on individual cases. So I'm a little more comfortable with waiting maybe 24 hours, 36 hours maybe, to ensure there's not ongoing bleeding prior to initiation of chemical prophylaxis in lower grade injuries. And as the guidelines do call for from the AAST, around 48 hours after stability is achieved in higher grade injuries. This is accounted for within the Western Trauma Association recs, but the WTA recs fail to make the distinction for higher grade trauma, which I think is better accounted for in the AAST approach. So the guidelines are what they are, but personally, and looking at the primary literature behind it, I would argue more for kind of a modification of the AAST approach where you wait and make sure that the patient has been stable for 24 hours, not just hemodynamically, but also from a hemoglobin standpoint, from a urine output standpoint, etc. And then for lower grade injuries, start prophylaxis at that point, maybe even with follow-up cross-sectional imaging to assure that there's no development of pseudoaneurysm, that there's no blush, there's no ongoing significant bleeding. Ditto with grade 4 and grade 5 injuries. If you've not operated them, then consider all of this at 48 hours, so a little bit later on after stability. And again, I think there is a place, as the group out of Memphis and others have shown us, for getting follow-up CT scans, follow-up cross-sectional imaging in patients at risk for pseudoaneurysm development after significant hepatic or splenic trauma. And certainly mechanical prophylaxis on all these should be started, unless it's contraindicated for some reason due to orthopedic injuries, early on. But in regards to chemical prophylaxis, I think we need to make sure that this bleeding is not persisting or certainly worsening. Okay, let's move on now to look at CNS injuries. You know, few inter-service conflicts, at least in my experience, are more prevalent with trauma patients than those between neurosurgery and trauma surgery regarding questions of anticoagulation in patients with traumatic brain injuries or spinal cord slice-vertebral injuries. And let's tackle TBIs first. Certainly from a neurosurgical perspective, patients with TBI present particular concern with VTE chemical prophylaxis because provocation of bleeding within the intracranial vault can have devastating consequences with even small volumes. At the same time, TBI patients have very high VTE risk, ranging between 40 and 80% in the Toronto trial, likely related to significant tissue factor release. The data on timing and initiation of VTE chemical prophylaxis in the traumatic brain injury setting is unfortunately limited in nature. The only quality prospective experience currently is the delayed versus early enoxaparin prophylaxis 1 or DEEP 1 trial, which was a small multi-center Western Trauma Association study with 62 patients studied on the Parkland protocol. The Parkland protocol uses a modified Byrne-Norwood criteria, along with consideration of whether a patient has required procedural intervention and has stable cross-sectional imaging after 24 hours to stabilize patients, or to stratify patients, I should say, into 3 groups. Low risk TBIs, in which case it's recommended that Lovenox be started after 24 hours with a stable head CT. Moderate risk, in which case patients can start Lovenox after 72 hours and 24 hours after stable head CT. So 72 hours after presentation, 24 hours after the first stable head CT. And those patients with high-risk TBIs, in which chemical prophylaxis is avoided for greater than 72 hours, and secondary prophylaxis with weekly duplex studies is recommended. Central to this is this modified Byrne-Norwood criteria. What is that? So basically, a subdural hematoma greater than 8 millimeters or an epidural hematoma greater than 8 millimeters, the presence of a contusion or intraventricular hemorrhage greater than 2 centimeters, multiple contusions per cerebral lobe being noted, or subarachnoid hemorrhage with an abnormal CT angiogram. If any of these things are present, then you're dealing with a moderate risk TBI that you should wait longer on. If none of these are present, then you can be more aggressive, as the patient is classified as having a low-risk traumatic brain injury. What did the study show, though? The delayed versus early enoxaparin prophylaxis 1 or DEEP 1 trial demonstrated that use of VTE chemoprophylaxis as guided by this protocol was safe with equivalent intracranial hemorrhage progression relative to the control group. There was also a trend noted toward decreased VTE rate compared to the group which did not receive chemical prophylaxis, as noted here in green. The study was not, however, large enough to reach statistical significance. Several other more sizable but retrospective studies, highlighted in yellow here, appear to also support the Parkland approach, demonstrating that with predominantly non-surgical TBI patients, so not typically craniotomy patients, use of VTE chemical prophylaxis is safe and effective within 24 hours after a stable head CT, whereas use of chemical prophylaxis after craniotomy was associated with increased need for repeat procedural intervention. And so post-craniotomy patients, really, we need to be a lot slower to try to put those patients on chemical prophylaxis. So with that background, let's look at the guidelines now. The AAST guidelines endorse utilization of the Parkland protocol with utilization of the Byrne-Norwood criteria to guide the timing of chemical prophylaxis in regards to VTE. And note again that if you don't have an epidural or a subdural greater than 8 millimeters, or a contusion greater than 2 centimeters, or intraventricular hemorrhage greater than 2 centimeters, or multiple contusions or subarachnoid hemorrhage, or evidence of progression, then your low risk chemical DVT prophylaxis can be started after 24 hours with a stable head CT. If any of those things are present, you're moderate risk and you need to wait 72 hours before starting chemical prophylaxis and at least 24 hours after a stable head CT, both of those criteria. High-risk patients, meanwhile, are those that have had a craniotomy, have an ICP monitor in place, or who have evidence of progression even after 3 days. And in those instances, it's more of a secondary prophylaxis with just monitoring and withholding of chemical prophylaxis. Certainly, mechanical prophylaxis is appropriate, though. So the AAST guidelines, again, recommend following the Parkland protocol with the modified Byrne-Norwood criteria for starting of timing of DVT chemical prophylaxis. And then when you start it, they recommend starting at the lower end of things instead of going to the 40 BID, going to 30 BID of Lovenox in those instances. The Western Trauma Association recommendations, meanwhile, just call for initiation of VTE chemical prophylaxis within 24 hours of a stable clinical exam and head CT without differentiating the type of TBI and whether or not the patient required a craniotomy. So I think the AAST criteria in this regards are more nuanced, and I'm more comfortable embracing those or slight modifications of those as compared to the WTA guidelines here, which really do not provide much distinction between the more severe head injuries, which might be more risk, and those at lower risk. Somewhat surprisingly, the neurosurgical literature in this area is fairly unimpressive, and the guidelines from the Neurocritical Care Society are pretty aggressive, just flatly recommending VTE chemical prophylaxis within 24 to 48 hours of TBI and within 24 hours of craniotomy, which, based on some of the data that we've touched upon, I'm not really comfortable with. And so to me, the AAST guidelines here appear to be the most nuanced and appropriate from my perspective. Patients with injury to the spinal column and cord are well known to be at elevated VTE risk, but literature on the subject is of limited quality and quantity. Part of this is related to the heterogeneity of these injuries. An isolated compression fracture of a single vertebrae with no motor sequela is much different than a patient permanently paralyzed due to a spinal transection. Such variability in injuries argues for a somewhat nuanced and case-by-case basis for when and how VTE prophylaxis chemically is initiated and maintained. Having said that, the predominance of current studies favor initiation of VTE prophylaxis within 48 to 72 hours, and this is reflected by both the AAST and the WTA guidelines, as well as the neurocritical care recommendations supporting initiation typically within 48 to 72 hours in the absence of contraindications. Additionally favored by some is consideration to obtaining an MRI of the spine to rule out epidural hematoma after an interval of trauma, but prior to initiation of prophylactic and certainly before therapeutic anticoagulation, which is something that I do not too terribly infrequently. So regarding the timing of VTE prophylaxis initiation, it appears that the majority of vertebral and spinal cord injuries can have VTE prophylaxis within 24 to 48, or at the very least 72 hours of injury. In some instances, the risk of epidural hematoma and other issues are too great, and these patients should have mechanical prophylaxis alone and serial duplex studies with IVC filter placement if thrombosis develops. And again, when anticoagulation is initiated, it's typically going to be with the lower dose end of enoxaparin at 30 milligrams BID. The trauma teams at Denver, UCSD, UCSF, and Hopkins recently formed the Consortium of Leaders in the Study of Traumatic Thromboembolism, or CLOT. As part of this initiative, the CLOT-1 trial studied risk factors for post-traumatic pulmonary thrombosis and demonstrated that what we have often called pulmonary emboli are more often primary pulmonary thrombosis and less often a true embolic event. And we'll talk more about this data in a separate discussion. But I mentioned the CLOT group now because a secondary analysis of the CLOT-1 data was conducted looking specifically at the subset of patients with spinal cord injuries. From the original 7,880 CLOT-1 study patients, 343, or 4.4%, had spinal cord injuries. Of these, 33, or 9.6%, had some sort of venous thromboembolism. 30, or 8.8%, had a documented DVT. 3, or just shy of 1%, had a PE, and 11, or 3.2%, had a pulmonary thrombosis. Factors associated with increased VTE risk included use of unfractionated heparin rather than low molecular weight heparin, as you can see here, missed doses of VTE prophylaxis, and VTE prophylaxis being initiated more than 48 hours after presentation. 3 patients had bleeding complications, so a low incidence, less than 1%. 1 of these was wound bleeding, 1 was recurrence of bleeding from a hepatic laceration, and 1 developed a GI bleed. There were no instances of epidural hematoma or other spinal bleeding complications in these patients with spinal injuries started on VTE prophylaxis. So although this study wasn't cited by the AAST or the WTA publications, I believe it lends further support to their guidelines and to the guidelines of initiation of chemical VTE prophylaxis within 24 to 48 hours of stabilization of spinal cord injuries. How long are these patients at risk, though? How long do these patients remain at risk? I mean, if someone's paralyzed, for example, do they need perpetual chemical prophylaxis? Investigators at UCSD sought to answer this by reviewing data on all California trauma patients from a statewide database between 1995 and 2010, specifically looking at pelvic fracture patients, vertebral fracture patients, and spinal cord injury cases. Not surprisingly, they found that spinal cord injuries were associated with the highest risk of VTE. The most significant vulnerability to VTE within these patients was seen within the initial 3 months after injury, as you can see here, and was actually highest with thoracic, although fairly close across the board amongst all. But the highest risk was at 3 months, the first 3 months. By 6 months, the risk, you can see, has declined significantly. Although it never quite gets back to the general population baseline of 0.1 to 0.2%, it does get significantly lower after 3 to 6 months. And this is congruent with hematology, neurology, and PM&R literature indicating the window of significant risk for these chronically immobilized, paralyzed patients, during which VTE prophylaxis should be maintained, is somewhere between 3 to 6 months, although you could potentially, based on this data, make an argument for out for a year. But for the most part, in our patients that are tragically left paraplegic or quadriplegic as a result of their trauma, how long should they be maintained on VTE prophylaxis? Probably somewhere between 3 and 6 months, depending upon the case. Dr. Zazan has done a good job of synthesizing all of this data and in particular, I think the strengths of both the AAST and the WTA guidelines into an institutional set of guidelines for us here with our Mount Carmel trauma team. And let's finish our discussion on VTE prophylaxis and trauma by reviewing these. Patients with minimal injury and going home within a day, it can be argued to do nothing, as highlighted here in the orange. Everybody that stays overnight, though, gets mechanical prophylaxis, typically with bilateral SCDs. If you can't do both sides, do one side. If SCDs aren't practical, use foot pumps. And again, early ambulation whenever, as soon as it's possible and appropriate. Patients with ongoing bleeding, spinal traumas, and head trauma, as highlighted here in the red, may or may not be candidates for early chemical prophylaxis. Everybody else gets chemical VTE prophylaxis. Unfractionated heparin, if they have renal failure, as defined by a creatinine clearance of less than 30, and 5,000 Q8 in most, 7,500 Q8 with a BMI of greater than 30. Patients with a normal creatinine clearance get Lovenox 30 milligrams BID, or if the BMI is greater than 30, the protocol calls for 0.5 milligrams per kilogram BID after the AAST guidelines. And again, I would add in here to consider maxing out at somewhere around 60 to 70 milligrams BID. And in regards to the question of 30 versus 40 milligrams BID, we stuck with the 30 BID in non-obese patients given lack of validation of higher doses, giving lack of validation of higher dose safety in the absence of anti-10A monitoring, which we are just dubious about the benefits of and whether it's worth the expense and the hassle at this time. Now, to look at those more problematic patients, here highlighted in the red, in patients with TBI, we are following the AAST approach and utilizing, and the Parkland approach, and utilizing the modified Byrne-Norwood criteria with initiation of 30 milligrams BID of low molecular weight heparin, or in the case of renal failure, unfractionated heparin, 24 hours after a stable head CT with low risk injuries, 72 hours after stable head CTs with moderate risk injuries, as defined by the modified Berne-Norwood criteria, and taking a secondary prophylactic approach to patients with high risk injuries with weekly bilateral lower extremity venous duplex studies. In patients with spinal cord injuries, 30 milligrams of BID low molecular weight heparin should be started within 48 hours of stabilization. And I would again add that consideration of MRI to rule out small epidural hematomas can be argued for on a selective basis, not wanting to see those potentially blossom if they are present. Cases of solid organ injuries being managed non-operatively can be started once hemodynamically stable. It's the only part of the guidelines I have some hesitation on. Personally, I think the risk-benefit ratio argues for an interval of not just hemodynamic instability, but also hemoglobin stability, and in some instances, confirmatory follow-up cross-sectional imaging in these patients before initiating chemical prophylaxis. Now, one thing that our institutional guidelines, as well as the AAST and the WTA guidelines, do not incorporate is the question of aspirin as DVT prophylaxis. A significant body of orthopedic literature supports the use of aspirin for VTE prophylaxis after joint replacements and other orthopedic procedures. And this recently led to interest in utilization of aspirin in patients undergoing orthopedic procedures in the setting of trauma. The most significant of these studies so far was the experience published in the New England Journal of Medicine in January of 2023 with 12,211 patients who presented with upper extremity or lower extremity fractures requiring operative intervention and patients with both operative and non-operative pelvic fractures. And they were randomized to receive either low molecular weight heparin, 30 milligrams BID, or 81 milligram of aspirin BID. Of note, these were not a group of severely injured polytrauma patients. The median ISS was 9, and the mean hospitalization was just 5 days. They found essentially equivalent dosing adherence on the inpatient side. So they had basically 95 and 97% of the aspirin and the low molecular weight heparin group got the medications as they were prescribed. On the outpatient basis, there was a slight trend toward better adherence with aspirin in the outpatient setting over Lovenox at 90% versus 85%. In regards to VTE and bleeding complications, there was no difference between the two groups. So it was a non-inferiority study that did indeed show that aspirin was non-inferior at 81 milligrams BID to Lovenox 30 milligrams BID. My takeaway from this study is that BID low-dose aspirin is a viable option for DVT prophylaxis in patients with isolated orthopedic injuries who still require DVT prophylaxis after discharge. I do not see a benefit to this in the inpatient setting. Additionally noteworthy is the understanding that the BID dosing of aspirin was utilized solely to be better able to compare compliance with BID Lovenox, so that you had two BID meds, because obviously it'd be easier to be compliant with the medication you were just given once a day. Pharmacologically, one would really expect daily aspirin to be equally efficacious. So do we really need to dose these patients that we're going to continue on with DVT prophylaxis in the form of aspirin twice a day, or is once a day sufficient? Pharmacologically, one would argue that probably once a day would be sufficient. But I do not see benefit to this in the inpatient setting right now. In the outpatient setting, where compliance is a little more of an issue, yeah, I think it certainly is a reasonable thing to consider. Okay, with that, I believe we've hit the high points of VTE prophylactic dosing in relation to trauma. We'll call it quits for now, and then we'll look at some other specific surgical subsets of patients in the next podcast.